So the next thing we want to talk about is evaluating some of the injuries and doing some management techniques in trauma. Things that are important to us in the patrol room, which is a little different than the EMS environment, because chances are good we're going to be able to discharge a lot of our patients to go to a walk-in care or an emergency department on their own, or maybe even to follow up with their own doctor. So let's talk about some clinical prediction rules that we use in our protocols for assessing those patients. So, knee injuries, very common in skiing. And so, you've got someone complaining of knee pain. We use something called the Pittsburgh knee rule, which determines whether or not they need an x-ray and how urgently they need the x-ray. So, was there a blunt trauma or fall mechanism? Did they hit the knee? Just standing and twisting the knee does not break the knee unless it is a tremendous twist. So in skiing, theoretically, you could break the knee with a twisting injury if you were skiing when it happened, but then you're going to fall. So if there was no blunt trauma, there was no fall, ACE wrap on the knee, they follow up with their own doctor as needed. If they're less than 12 or they're older than 50 and they had blunt trauma or fall, then you immediately immobilize them. They need to go to the emergency department or walk-in care for x-rays. That group, we can't predict fractures as well as we can for people who are 13 to 49. So they had blunt trauma or a fall. Their age is 13 to 49. Now you have them walk. If they can walk 4 weight-bearing steps, and that doesn't mean they have to jump up and down on the affected side. It means that they need to be able to put their body weight onto that side, even if it's a quick hobble. They put their body weight onto that knee. If they can do that for 4 steps, then immobilize with an ACE wrap and they follow up with their own doctor as needed. If they can't do that, immobilize it, ACE wrap or quick splint or cardboard splint, and send to the emergency department or walk-in care for x-rays. We see a lot of wrist injuries too. And so for wrist injuries, we check the neurologic function, we check circulation. And neurologic function, we check the median, the radial, and the ulnar nerve. And so what are we checking? So here's a hand, the wrist is injured. We check the median nerve, ulnar nerve, and radial nerve for sensation. So we touch the small finger, we touch the bottom of the middle finger, and we touch the top of the thumb. So that's sensation, median, radial, ulnar nerve sensation. Then we ask the patient to spread their fingers wide. It's ulnar nerve. We ask them to touch their small finger to their thumb. That's median nerve function. We ask them to pull their hand back like they're saying stop. That's radial nerve function. So we check median, radial, and ulnar nerve motor and sensory function. We check distal circulation, so that's basically check capillary refill, and that's about it. If the injury is proximal to so somewhere back here, proximal to the radial artery, you could check the radial or the ulnar artery. So radial ulnar artery on the thumb side, ulnar artery on the small finger side, and see if they have circulation there. But it's basically going to be capillary refill, distal capillary refill for circulatory function. Look for evidence of deformity. You want to splint it in a position of function, which basically the position of function looks like this, like they're holding a can with their wrist cocked back slightly, so a splint underneath that holds it in place. If they're neurovascularly intact, so they had passed all the neurologic exam and they have good capillary refill, they just need to go get x-rays, walk-in care, emergency department, talk to their doctor. If they're neurovascularly compromised, so they have a problem with the neurologic exam where they don't have circulation, the hand is pale or cool, there's no distal capillary refill, offer them EMS, and if they say I'd rather go on my own, refer them directly to an emergency department because they're going to need to have that injury straightened to get back function. We see a lot of people with shoulder injuries. We do the same neurovascular checks that we do for the wrist, with the addition of right here where a patch would be on the arm, like if patch would go right on there. If we were sewing a patch on, check sensation right there. For patch anesthesia, we worry about that in patients with shoulder dislocation, so you add that on to your exam. Put them in a sling and a swath with cravats or triangular bandages. If they're neurovascularly intact, they can go anywhere for x-rays. If they've got any neurovascular compromise, offer them EMS and refer them directly to the emergency department. We use selective spinal immobilization, which means deciding who needs to be immobilized in a cervical collar and on the long spine board. Now this is changing in EMS, and there will be changes to this protocol, I suspect, in the 2015-2016 season, but for now we're continuing with what we've traditionally done. So if the patient's unreliable, they're intoxicated, they have a head injury, spinal immobilization, cervical collar, long spine board. If they have C-spine pain or tenderness, immobilize the C-spine. If they have a distracting injury, a fracture, an amputation, something else going on, immobilize the C-spine and the full spine. If they have an abnormal sensory exam, immobilize them. Or if they have tenderness along the lower spine, immobilize them. Now, on the hill, we will often immobilize people just because we don't know for sure. It's hard to do the exam. We need to get them off the hill. Do that. Once you have them in the aid room, you can go through this process to take them off of the spine board if they don't need it. And if you come to a finding where you do need to keep them immobilized, then you immobilize them. But just by putting them on a board on the hill, you are not committing them to being transported by an ambulance for further evaluation. We have the ability to take people out of spinal immobilization once we have them in the warm, dry, well-lit aid room and can do a good exam. If they're wearing protective headgear, and hopefully most of our patients will, you need to decide to remove it or not. For the most part, we try to remove them if we can. If you can't access the airway, you need to take it off. If you can't assess the airway, you need to take it off. If it's loose, you need to take it off. If you can't immobilize the spine with it on, you need to take it off. And if there's any other reason you think you need to take it off, take it off. And frankly, I would say most of the time you need to just take them off. You'll need a minimum of 2 people to do that. For ski boot removal, just review that in the OEC. It's going to take at least 3 people to do it, and I mentioned with femur fractures, you're going to want a 4th. It's not easy to do that and keep a patient immobilized and comfortable. For pain management, we can reassure them, we can put a splint on, we can offer them ice or snow in a Ziploc bag. We don't have anything stronger than that. Okay, go ahead and complete the knowledge assessment on those areas.